Well, can't watch this. Gotta turn on the audio today. Sucks. Can we go home?
adolescents. And lower adjusted odds of inhaled steroid use and daily anti-inflammatory meds. And then there are mental health disparities. So Latinos have significantly higher unmet needs for mental health care, lower odds of any mental health visit, outpatient visits, antidepressant prescriptions, and receiving treatment from a mental health specialist for any condition, behavior problems, or depression, higher odds of developmental delays, lower odds of being diagnosed with externalizing behavioral disorders, and a lower odds of use of mental health services among children being investigated for possible abuse or neglect. And now we want to talk about disparities for American Indian, Alaskan Native children. So in terms of mortality, they have a higher age-specific crude mortality rate versus whites, both in national and urban samples, then higher adjusted risk of death among those with ALL. They have a firearm injury rate that's more than 7 times higher than for white children, a higher adjusted odds of overweight and obesity. The birth rate for AIAN female adolescents is almost triple the birth rate of whites, higher adjusted odds in white children of poor or fair health, and it's actually the highest prevalence of these suboptimal health ratings of any group. And then there are mental health disparities. So within 6 months of a new depression episode, they have lower adjusted odds in white children of having any antidepressant prescription being filled and any mental health visit or antidepressant prescription being filled. And for those in substance abuse treatment, lower adjusted likelihood of mental health services use. So I don't want to just paint a negative picture here. There are lots of disparities. So is there any positive news? Well, I'm here to tell you that parent mentors eliminate children's healthcare disparities. And so what is a parent mentor? So this is a special category of community health workers for children in which parents who have children with a particular health condition or risk leverage their relevant experience along with additional training to assist, counsel, and support other parents of children with the same health conditions and risks. And 2 rigorous randomized controlled trials by our team demonstrate that parent mentors actually eliminate children's healthcare disparities, improve children's outcomes, including enhanced healthcare access and quality, empower parents, reduce family financial burden, save hundreds or even thousands of dollars per child from a societal perspective, and create jobs in areas with the highest unemployment rates. So let's turn to the first study, which is a randomized controlled trial of the effectiveness of parent mentors improving asthma outcomes in minority children. If you want more information, these studies I think are posted electronically in their entirety. So as background, asthma disproportionately affects minorities. Only 3% of white children have active asthma versus 6% of African American and 11% of Puerto Rican children. Compared with white asthmatic children, African American asthmatic children are 3 times more likely to be hospitalized and 5 times more likely to die. But few studies have evaluated interventions to improve asthma outcomes in minority kids, and before our work, no study had examined the effectiveness of parent mentors. So we wanted to determine whether these PMs are more effective than traditional asthma care in improving minority children's asthma outcomes. So the methods were as follows. This was a randomized controlled single-blinded trial. The staff assessing the outcomes were blinded to the group allocation. Participants were randomized to the parent mentor intervention plus their traditional asthma care or just a control group that only got their traditional asthma care alone. Participants were recruited from a consecutive series of minority kids 2 to 18 years old. Eligibility criteria were residing in Milwaukee, where I was at the time. They had to be seen for asthma between 04 and 07 in 1 of 4 EDs, and then or the primary reason for hospitalization at a major children's hospital. So what was the parent-mentor intervention? So intervention families were paired with these PMs who are experienced minority parents of asthmatic children from the same communities. The parent mentors received 2.5 days of training and a 73-page manual in English and Spanish on childhood asthma, but also assisting families with unmet needs for health insurance, housing, food, and other social determinants of health issues. You can download this manual on the trainer resource for free at this website here, which again, we can make available online. And the parent mentors met monthly with up to 10 asthmatic children and their families at community sites. They phoned the parents monthly and made 2 home visits. And now, if this is cooperating, we'll be able to see an actual clip.
Hi.
Hello. Hi, you're Shona?
Yes.
Hi, Shona. How are you?
I'm wonderful. How you doing?
That's good. I'm okay. I'm Natasha. I'm your parent mentor from Parents Health and Parents Fight Asthma.
Oh, it's nice to find you.
I'm the one that called you so we can set up this home visit for today.
Wonderful. Why don't you go ahead and have a seat?
Thank you. So how have you been, Shona? Since I've spoken to you, that's good. And how's Brandon?
He's doing well. He's upstairs sleeping now. He's been doing okay since I visited.
And how have the meds been working?
I guess so far they're doing fine. He's been sleeping a lot, but
What did they exactly give you in the ER?
they gave Brandon albuterol and Palmcort.
Okay.
And he's supposed to get the Palmcort only if he has like a reaction or anything like that. So it's just for like emergency.
Okay. Right now he's having a point where he's sick and his asthma is flared. So they will give you an asthma care plan in the ER, and the asthma care plan breaks down what you should do over so many days until you see your primary care physician. Some of the things that we can do, like we have the peak flow meter. And once you see your pediatrician, these numbers, these levels here will be set, these knobs here. This little red button here will move up and down.
Okay.
It'll go up. So wherever they're set to, you'll know what his breathing should be. He'll need to do this daily.
Okay.
And this is just simple. So he would take in a deep breath and preferably have him stand, that way the airway will be open more. And he'll just take a deep breath in, make sure he puts a tight seal around here, this part here,
Okay.
a seal around here, and then he'll blow. And that might even be fun for Brandon. So that one, right, would not be a problem. Are you having any problems with Brandon taking his meds right now?
So far he's actually okay with
He's
it.
doing okay. Well,
Yeah.
that's really good. This one here, like I said, albuterol is a rescue medication.
So that gives you a little bit of an idea of what goes on. So we looked at 12 outcomes in this study: asthma symptom and exacerbation frequency, missed school and parental work due to asthma ED visits and hospitalizations. Looked at parent and child quality of life using a couple of instruments, something called the PAC-QLQ and the PEDS-QL. Did a parental satisfaction with physicians' asthma care, a parent asthma management self-efficacy scale known as PAMSES. We also looked at costs and cost effectiveness. We did intention to treat analysis, but we also did a stratified analysis looking at the outcomes for high participants in the intervention and also by disease severity. And high participants were defined as those attending at least 25% of monthly community meetings, and then completing at least half of the monthly PM phone interactions. So the results were as follows. So we assessed a total of 648 for eligibility. We had to exclude 428 for a variety of reasons. So we randomized 220, 112 in the intervention group and 108 in the control group. And we had about a 60% follow-up rate. These are the characteristics of the study parents. In the first column is the characteristic, in the second column the means or percentages, and you can see that the average age was about 32. Most were female. About 17% were married, living with a spouse. 25% had education beyond high school. 40% were employed full-time. So 81% African American, 19% Latino, 13% had limited English proficiency, and most were low income. 68% were poor, and 25% were 101 to 200% of the federal poverty level. The kids averaged about 7 years old, about equal male-female distribution. Most of them had a primary care provider, but only 21% had an asthma specialist. The ED was the most likely place to be taken for asthma care by 64%. You can see they averaged about an asthma attack every month, 12 per year, 9 missed school days per year, 8 parental missed work days, 3 ED asthma visits per year, and 1 hospitalization for asthma in the past year. And there were no significant intergroup differences for the kids or the parents. So what we did see was significant changes in outcomes. So this is the intention to treat analysis. Your first column is the outcome, second column baseline, and then third column the endpoint. Final column is the p-value. So you can see in terms of rapid breathing episodes for controls, there was no change. For intervention group, they had a significant drop. Asthma exacerbations, both groups actually had some reduction that was significant. And then ED visits for asthma, there was no significant change for the controls, but a significant drop for the intervention group. So I want to look into this a little bit further to see, did it make a difference if you participated a lot in this program or very little? And so here you see the outcomes and the comparisons and the p-values, but now we're looking at controls, low participants and high participants, and you can see, you look at wheezing episodes, actually was no change for controls or low participants, but for the high participants there was. All the groups had reductions in coughing episodes, and in terms of difficulty breathing episodes, controls had reductions and the high participants had the greatest reduction, but there's no difference in low participants. This shows the mean number of asthma exacerbations comparing their first and final month. Your y-axis is the exacerbation number, x-axis the 3 different groups. We're looking at the final month in red versus the first month in blue. You can see no change for controls or low participants, but a major change for the high participants. Look at the mean numbers of missed school days. Comparing the first and final month, you can see that there was a significant drop among controls, not the low participants, and the greatest change among high participants. Mean numbers of missed work days, you see the same pattern, some reduction in the control group, not in the low participants and definitely in the high participants. And then the change in the PEDS QL score, there was actually an improvement, an increased score in the controls, nothing in the low participants, and then there definitely was in the high participants. Mean number of asthma ED visits, you can see no change in the controls in the low participants and actually substantial change in the high participants. And then this is the self-efficacy score, the PAMSEs, and the overall score, so higher is better. Actually wasn't statistically significant for all children. This is can control serious breathing problems at home versus taking the child to ED. There was a significant improvement among the controls, nothing in the low participants and definitely in the high participants. And then the only group that showed an improvement about no when serious breathing problems are controllable at home are the high participants. So we didn't see any significant intergroup differences in hospitalization rates or satisfaction survey scores, but the testimony of participants and mentors indicates high levels of satisfaction with intervention.
I think the knowledge is the best thing about the program, is what you learn. I mean, it's not just someone talking, they're answering questions, personal questions that you may have that may not pertain to everyone else. We're actually shown through demonstration different medicines that are used, different machinery that's used to administer the meds.
I've been an active parent mentor since August of last year. I have had, over the past year, about 7 to 8 families. And it's been a learning experience for me because I have 2 children of my own who also have asthma. And learning with my families the different disparities with asthma, the different severities with asthma, and how the different families deal with their asthma has allowed me to learn how I can deal with my own children with asthma. And we kind of learn from each other. So the program has been a great benefit for me.
It's taught me a lot of things to be aware of, a lot of signs, a lot of symptoms, how to keep, how to keep him from having a reaction, things of that nature. So if something happens to happen, I know what to do and, what the signs are and how to go about, going from there.
The information was so valuable just because my daughter has asthma. So I just learned some of the things that, I should be doing and wasn't doing. So it's just been such a great program to be a part of.
Well, I think it's a great program, and I've been part of it since the beginning. And I've seen a lot of families really improve and come a long way with treating their children's asthma. And I think one of the greatest things is we've all gotten to know each other really well, and the families have become pretty close. So it's a great program.
I feel like knowledge is key. If you know about it, then you can do something about it.
The support is what I got the most out of, the support in the answers. That's been very supportive of me. It's been very beneficial. And I actually wish I could stay in longer than a year.
So we also did a cost analysis. So here you see in the first column the item, the second column is the average monthly cost per patient. And so as you might imagine, the personnel were the most expensive, but it was only about $41 per patient per month. The stipends for the parent mentors are about $17. The one-time supplies and the 2.5-day training session averaged to less than $1 per patient per month. Monthly meetings were only about $1.50 per month. Bus tickets less than $1. So the total cost was not that great. It was about $60 per patient per month. And this is the cost effectiveness analysis. So what you're looking at are the savings and incremental cost effectiveness ratio. Your first column was a study group, then the program cost, hospitalization cost savings, ED cost savings, and then this is your golden number here. This is your incremental cost effectiveness ratio. So you can see the intervention, the program cost was about $121, hospitalization cost savings, $361, ED cost savings, $50. So the program actually saved about $600 per child per exacerbation avoided. The high participants, somewhat similar numbers, actually lower savings, but still savings per patient. So we concluded from this study that parent mentors are more effective than traditional asthma care in improving several asthma outcomes in minority kids, so reduced wheezing, exacerbations, and ED visits, fewer missed days of parental work, improved parental self-efficacy in knowing when a serious breathing problem can be controlled at home. The cost of the intervention was reasonable, averaging about $60 per child per month, but the intervention results in a net cost savings of $597 per child, and the PMs were especially effective with high participants in the intervention. Implications include PMs are a promising means for reducing racial and ethnic disparities in asthma and potentially other chronic diseases that some of you I know are working on and might want to think about this as a model for. And we saw that additional intervention benefits include community participation in the asthma care, enhanced social support and cultural sensitivity, relatively low costs, and jobs creation in often economically deprived communities, and that gets the attention of your policymakers. So we followed that up with a study entitled A Randomized Controlled Trial of the Effects of Parent Mentors on Ensuring Uninsured Minority Children. You can also download those publications and go to our website for further information. So as background, almost 4 million US children, that's 5%, are uninsured. That's actually gone up in the last year. And Colorado is similar. It's a little over 59,000. That's 5% uninsured. Interestingly, 90% of uninsured US children, so that's 3.5 million, are eligible for, but not actually enrolled in Medicaid and CHIP. And major racial and ethnic disparities exist, as you might imagine. So looking at 4% of white children are uninsured compared with 5% African American, 9% Latino. So before we did this study, not enough was known about the most effective ways to insure uninsured children, and no one had looked at the effectiveness of PMs. Our goal here was to conduct a randomized controlled trial to look at the effects of PMs on ensuring uninsured minority children. We wanted a snappy title. We call it Kids Help. This is Kids Health Insurance by educating lots of parents. My adolescent daughter came up with that one, so my thanks go out to her. So this was an RCT. Uninsured, Medicaid, and CHIP eligible Latino and African American kids were recruited at community sites, and we randomized them to PMs at the controls. Subjects in both groups were contacted monthly by a blinded research assistant who monitored outcomes for a year, and additional participants were followed up for up to 2 years after the trial ceased just to see if there was any momentum and inertia. So the setting was, at the time I was in Texas, so 7 Dallas communities with the highest proportion of uninsured and poor minority children. And we performed recruitment at 97 community sites. They included supermarkets, department stores, libraries, Goodwill stores, food banks, health fairs, churches, schools, and housing projects. So the PMs were minority parents in a primary care clinic who already had at least one Medicaid or CHIP covered child who had the coverage for that child for at least a year. The PMs underwent a 2-day training session which addressed the types of insurance programs, the application process, completing and submitting the applications with the parents, being a family liaison or advocate with the Medicaid and CHIP programs, renewing the coverage, obtaining pediatric and dental care and a medical home, and helping families with food, clothing, and other social determinants of health. We did a PM training evaluation, so a 33-item pre-test was administered prior to the training to assess knowledge and skills regarding medicating CHIP, the application process, and medical homes. A 46-item post-test contained the same 33 pre-test items ordered differently and 13 Likert scale questions on training satisfaction. And the PM training results, which are available in an ACPEDS article, were that all 15 PMs were female and non-white, 60% were unemployed. You can see the mean annual family income was low at about $21,000. After the training, the overall test scores on a 0 to 100 scale, with 100 the best, significantly increased from a mean of 62 to 88, which is significant. Number of wrong answers decreased, mean reduction was 8, and there were significant improvements in scores for 6 of the 9 topics, and 100% of the PMs reported either being very satisfied or satisfied with the training. So PMs met with families in their homes and at community sites and contacted them regularly via phone, emails, and texting. PMs would be following up to 10 families at any time, and data document high levels of PM engagement with the families, with means of about 20 home visits and 161 phone, email, or text messages contacts per family per year. Controls received Texas's traditional Medicaid CHIP outreach enrollment, which you can imagine is not very extensive and was pretty passive. So it was basically bilingual radio spots, TV and newspaper ads, bus messages, websites with application links and order forms and materials for community-based organizations, and then daycare center outreach. The outcomes were assessed monthly. They included the proportion of kids who got insurance, a time interval to getting that insurance, coverage renewal, access to medical and dental care, the out-of-pocket costs of care and family financial burden, parental satisfaction, quality of care, and then we used 82-item baseline and 67-item 12-month and long-term questionnaires, which are derived from national surveys, and published studies also did a cost-effectiveness analysis. So the results were as follows. So we actually approached over 49,000 potential caregivers, and a lot of them had to be excluded because they were already covered or didn't meet other criteria. We randomized of 329, 179 to the intervention group, 157 to the control group. We had some exclusions, but we actually had a very high retention rate. It ended up being 123 and 114 respectively that actually were followed up at 12 months. This shows the participant baseline sociodemographic characteristics. You have the characteristics in the first column, and then the controls and the PM groups in the respective second and third columns. Average age was about the same. There was a slight preponderance of females in the PM group versus the controls, which we adjusted for later. See, race and ethnicity is about 2/3 Latinos, 1/3 African American. A good number of the parents were not high school graduates. A good number were not employed. And then the annual family income, as you would expect, was low at about $23,000. And the mean months uninsured was about 17 in controls and 11 in PM group. We again adjusted for those differences. So what were the results in terms of obtaining health insurance coverage? We found a significantly higher proportion of the parent-mentor group obtained health insurance versus controls. It was 95% versus 68%, highly significant. The PM group had a significantly higher adjusted relative risk, 1.3, or if you like odds ratios, it was 3 of coverage, and after you adjusted for the child's age and gender, citizenship and employment of the parent, and family income. This slide shows an adjusted propensity curve. Your y-axis is percent insured. The x-axis is time to insurance. Your looks like red, the orange here is control, and pink is intervention. And you see a marked sustained difference between the two groups in obtaining insurance. It emerges at about 100 days, and you can see it's sustained. In terms of time to coverage, renewal rates, and long-term coverage, you can see that the median number of days to obtaining insurance, 140 in the controls, only 62 in the PM group. Renewed insurance, 60% versus 85% in PMs. The 2-year coverage rate is after a year after the program ended, 76% in controls among those who got insured, and then 95% in the PM group. And 3 years out, it was 76% versus 100%, and these are all statistically significant. What about access to care? You can see having no PCP, 39% of the controls, only 15% of the PM group. No usual source of preventive care, 7 versus 1. Different sources for their sick and preventive care, 27 versus 15%. Never or only sometimes gets immediate care from their PCP, 19 versus 0%. And then problems getting specialty care, 46 versus 11%, all statistically significant. What about unmet needs for medical and dental care? You can see that didn't receive all needed care for healthcare overall, 25% of controls, 13% of the PM group. Preventive care, 22 versus 4%, acute care, 20 versus 3, and dental care, 31 versus 18%, again, all significant. What about the out-of-pocket costs of care? So you can see for all doctor visits, we're looking at a mean of $37 for the controls, 33 for the PM group, statistically significant. Sick visits, it was 43 versus 9. The others were not statistically significant, but all trended in the right direction in favor of the PM group. This slide shows parental satisfaction with the process of obtaining insurance. So y-axis is percent, x-axis the 5 choices the parents had, and you're looking at the orange is the control group, and the pink is PM intervention group. So you can see that the PM intervention group much more likely to be very satisfied or satisfied, and much less likely to be dissatisfied or very dissatisfied. And in terms of satisfaction with care, quality, and family financial burden, you can see that 16% of the control group would not recommend their child's healthcare provider to friends, 6% in the PM group. Dr. Never sometimes respects you're the expert on the child, 23 versus 11%. The mean overall quality score, so this is a child's well-care visit where 10 is the best score. The mean was 8.6 in controls, 8.9 in the PM group, and then needed additional income to cover the child's medical expenses, 13 versus 6%, again, all statistically significant. The intervention costs were not unreasonable, so the PM stipends were about $33 per patient per month. Personnel was about $16. PM travel costs about $2. One-time supplies about $1. The 2-day training session and PM meetings averaged to less than $1. So your total was about $53 per patient per month. How about the costs and cost effectiveness analysis? So you can see that there was a significant cost for the PM and program coordinator costs, about $86,000. The ED visit difference, though, controls slightly greater, about $63,000 versus $61,000. Hospitalizations, $81,000 versus $58,000. ICU stays, $277,000 versus about $75,000. And then their wage loss and other costs of parents who missed work days due to the child's illness, it was about $34,000 versus about $13,000. So the total costs were about $455,000 for the controls, about $293,000 for the PM group. When we calculated the incremental cost effectiveness ratio per child insured, we saved over $6,000 per child insured per year. So I want to show you some feedback on the program.
This program is very beneficial, not only for the community, but for the health professionals having to deal with unpaid medical bills.
Parent mentor helped me by any questions that I had, concerns. I can call her day or night. She was a big help.
I enjoy doing it because I help others. Teach them and show them that they can qualify if they send the right documents, and so long as they have an income and their child have Social Securities and they're born in the U.S., that they can qualify just because they're not.
I talk to a person like Valencia who has children who can explain to you like, my kid has gone through something similar to that. I don't know all the programs. I've worked for 40 years of my life and I've never had to rely on a program. So did I know what to do? No, but she knew what to do.
I think it's a big difference when you have insurance. You don't have no problem being seen in and out, but when you don't have insurance, it's a big problem. She was always there guiding me, and after 2-3 days I had my insurance. I was very happy about that. It was make life more easier with health insurance.
The Kids Help is definitely an organization that you should look into. You should actually take a moment and sit back and think about how wonderful an organization like this would be to your community.
So we concluded from this study that PMs are significantly more effective than traditional Medicaid and CHIP outreach and enrollment in insuring uninsured minority kids, getting the insurance faster, renewing the coverage, improving access to medical and dental care, reducing unmet needs and out-of-pocket costs of care, achieving parental satisfaction and quality of care, and teaching parents to maintain children's coverage up to 2 years after the intervention ceased. The PMs are relatively inexpensive at about $636 per child per year, but highly cost effective, saving over $6,000 per child insured per year. Implications include, given that up to 3.5 million US children are uninsured and Medicaid or CHIP eligible, and 53% are Latino or African American, the findings suggest implementing PMs nationally for minority kids could save over $12 billion. And if PM interventions are shown to be effective for all racial and ethnic groups, the findings suggest that implementing PMs nationally for all uninsured children could save about $22 billion. And PMs, analogous peer mentors for adults, could prove to be highly cost-effective interventions for eliminating disparities and ensuring all Americans. And we had some nice translation into policy. So based on our work, the federal CHIP reauthorization legislation signed into law in January 2018 makes organizations that use PMs eligible to receive $120 million in grants for CHIP outreach and enrollment. And all 50 states and DC, actually including Colorado, now have the opportunity to apply for CMS funds to implement the successful evidence-based Kids Help PM model. So I want to finish with 7 steps that you can implement to eliminate disparities and achieve equity. So first, race and ethnicity data as self-identified by the parent in the case of kids or by the adult in the case of adults routinely should be collected on all children and adults by practices, health systems, Medicaid and CHIP managed care organizations, and private insurers so that disparities can be identified, monitored, and targeted as part of QI efforts. Given the lack of significant change over time and the total number of disparities, together with the appearance of many new disparities and some work that our team did, the recommendation is consistent with 2 recent IOM reports, proposals by disparities experts, and actually the ACA. And disparities monitoring public disclosure, at least annually, should be considered by practices, hospitals, health plans, Medicaid and CHIP, counties, and states. Ensure that every child has health insurance in medical and dental homes because minority children comprise 59% of uninsured children, while they only constitute 48% of US kids. Latinos, American Indian, Alaskan Natives, and African Americans are significantly more likely to be uninsured and sporadically insured than white children, and multiple disparities exist and have persisted in lack of a personal doctor or nurse and in unmet dental needs, and it underscores the urgent need to ensure that every child has a medical and dental home. Racial and ethnic disparities must be framed and addressed as quality of care issues, given the substantial prevalence and this persistence of children's disparities, as pointed out by experts and recent IOM reports, and so disparities can be eliminated via rapid cycle QI and practice coaching. We need to ensure and advocate for all children to have access to needed subspecialty care. Children who need and receive care from subspecialists have significantly fewer ED visits and hospitalizations and a greater likelihood of health care consistent with national practice guidelines than children not receiving the needed subspecialty care. But minority children are significantly more likely than white children to have problems getting that subspecialty care. We need to aim to attain the highest level of cultural competency. We know that bias still exists in pediatric care. One JAMA study showed that in young children hospitalized for skull or long bone fractures, minorities were significantly more likely than whites to have a skeletal survey performed at 9 times the odds, and to be reported to Child Protective Services for suspected abuse at 4 times the odds. And in children and adults hospitalized for limb fractures, whites received significantly higher doses of narcotic analgesics, that's about 22 mg per kg per day of morphine equivalents, than blacks at 16 mg per day and Latinos at 13. We need to aim for the highest level of cultural competency, but a study of predictors of asthma care quality for Medicaid insured children found that patients at practice sites with the highest cultural competency scores are less likely to underuse preventive asthma medications with an odds of 0.15 and had significantly better parent ratings of overall quality of asthma care. So it really does make a difference. And we need to pursue workforce diversity. So African-American patients with African-American physicians in one study were found to be more likely than those with non-African-American physicians to rate physicians as excellent and report receiving preventive care and all needed medical care during the previous year. Another study found that Latino patients with Latino physicians are more likely than those with non-Latino physicians to be very satisfied with their health care overall. And workforce diversity is actually associated with nurse job satisfaction. And We need to leverage innovative evidence-based interventions. So rigorous evidence documents that intervening with community health workers, promotores, or PMs can reduce or eliminate many barriers and threats to children's health and healthcare through education, linking children and families to resources, providing social support, eliminating language barriers, and empowering parents. Studies additionally indicate that such interventions are cost-effective, and as we've seen, RCTs document that disparities actually can be eliminated using innovative, family-centered, community-based interventions, which also create jobs and save money for society. And solid evidence that CHWs, promotores, and PMs are highly effective in managing childhood asthma, reducing miscarriages and low birth weights, creating home environments more supportive of children's early learning from mothers with low psychological resources, obtaining early intervention services for young children, achieving high immunization rates, ensuring the uninsured, and identifying child food security in immigrant households. This evidence definitely already exists. And Colorado now has the opportunity to create a parent mentor program using that $120 million appropriation that I mentioned under the 2018 CHIP reauthorization, and CMS requested proposals in late 2018. So in summary, racial and ethnic disparities in children's health and healthcare are extensive, pervasive, and persist over time. Each racial and ethnic group has a unique set of disparities. Disparities, as we saw, occur across the spectrum of health and healthcare, including in mortality, access and use of services, prevention, population health, health status, adolescent health, chronic diseases, special healthcare needs, quality and organ transplantation. And using 7 steps, you can eliminate disparities and achieve equity. So we said routinely collect race and ethnicity data on all children and regularly identify, monitor, and target disparities as part of QI. Ensure every child has health insurance and medical and dental homes. Frame and address disparities as quality issues. Ensure that all children have access to subspecialty care. Aim for the very highest level of cultural competency. Pursue workforce diversity and leverage innovative evidence-based interventions like parent mentors. Thank you. I think we have a few minutes for questions, maybe?
Thank you. What's next on the horizon? What's the next innovation?
So we think that parent mentors would be a good innovation to look at a wide variety of chronic conditions, for example. So you could use it for diabetes or renal disease or kids with multiple chronic conditions. So we think that holds a lot of promise. I think people have been talking a lot about implicit bias, and so what can we do to change the playing field so that when we see a child, it's a child and not just a child of some race or ethnicity or sexual orientation or what have you. And so I think there's a lot going on in the education front so that our trainees are learning more about how we eliminate disparities. I know that there are a lot of states and the U.S. government that are looking at ways that we can help to improve the quality of care. There are grant opportunities now. You see NIH is now, I think, focusing on how can we fund disparities initiatives. And of course, there's the whole institute that's devoted to eliminating disparities, NIMHD. And so I think there are a lot of grant opportunities. And so I think there's a lot of potential now to really level the playing field and come up with interventions and research and clinical care and the education of trainees so that we can eliminate disparities in our lifetime. Yeah.
I was wondering, you have some wonderful testimonies from people who are involved in the program, but did you guys collect any early looking data analysis on exactly why the parent mentors were so effective? Like, what did they do that allowed more access to better?
Yeah, I think they did a few things. So first of all, they educated parents about the conditions. So in the case of those who had asthma, they helped them to understand the often jargon-filled gobbledygook that a pediatrician like I would give them during their visit in terms of beta-2 agonists, so they could translate that to parents. They helped them with health care literacy. So understanding, for example, in the uninsured study, that you need to have a regular primary care provider, you need to have a dentist, you may need to have a subspecialist, and you need to see them regularly. And then I think the social determinants of health were really, really important, because you can do all that, but if you are in a family that's suffering from hunger, or has their heat turned off, or has immigration problems, they need help with those social issues. And we know increasingly, as you're seeing in the healthcare field, that social determinants can often drive outcomes. And so I think that that was one of the most important things. And there were people from their community. In some cases, they bridged language barriers for the Latino parents who just couldn't understand everything that was being thrown at them in a language they didn't speak proficiently. And so I think that was a real winning combination. Yeah. Thank you.
In the slide you showed on the uninsured rates, the reach is like started with around 50,000 patients that were being evaluated and came down to 300 who qualified. Any thoughts about how to expand the reach of the numbers?
Yeah, so we decided to do something a little unusual this study. Rather than just sit in our hospital and wait for them to come to us, we decided to go out in the community and see what we could do. And so, yeah, we had to filter a lot of parents who their kids actually weren't eligible for the programs. It didn't take as long as we thought it would, because word of mouth traveled and a lot of people helped us on the street with it. And so part of it was also gaining trust, because I think a number of people initially just didn't want to be involved in it because of the stigma about medical research. And I think that getting the community buy-in was the most critical step in making sure that the program was effective. Yeah. Yes.
Thanks for the presentation.
Sure.
It's really informative. My question was for your first study. What metrics were used to determine if there was high participation? And then was there any like speculation as to why the high participation and the controls kind of followed similar trends and low participation within it?
Yeah, so we played around. I had a statistician play around with what would be the best threshold, because if you went too high, you wouldn't have enough people, and if you went too low, you'd have too many people. And so the magic numbers were the ones that I showed, which is, I think it was 25% and 50%. So that worked well for us. And so I think that then allowed us to look at, okay, if you participate a lot in the program, would that be helpful? And the question was why? And so at first we thought that the group that was high participants would be comprised of kids with the most severe disease. We were a little worried about that because that would distort things, but it turned out that wasn't the case. It seemed like that group of people was more concerned about their kids in terms of, nothing seems to be working, I want to try something new. And that's why we think it was so effective in that group, and not the low participants, because they really weren't engaged. And it's unfortunately a thing you see a lot of the time in studies, and people don't take the time to look at, okay, in the intervention group it worked well, in the control group it didn't, but can we separate out with whom it worked best and figure out the reasons? So we can only speculate because it was post hoc, but we knew that it seemed like those parents were more motivated because they felt like they had nowhere else to turn and nothing else was working with their kids. Hey, how you doing?
I just had a quick question. With the parent-mentor matches, was there always racial or cultural concordance, or if there wasn't, would you provide cultural or sensitivity training for the parent-mentor?
Yeah, we made sure that there was racial and ethnic matching, and as much as we could, we try to do it by neighborhood too, because I think that sent an important message that this is somebody in your community who's been through the same thing with their child, and so that resonates better than anything you can think of, really. And I think that's why it was so effective in terms of the matching. Yeah. Mm-hmm. Yeah.
Great talk. This was really informative.
Thank you.
It was really interesting to hear what you found. I'm curious, you mentioned the building the trust within the community and being able to work with them. But on the other side, you think about from an institutional perspective, I'm curious what that looks like in terms of getting buy-in / trust. Because a lot of times do projects like this, you have to do something with that, right? What you learn, you have to do something about it. And so I'm wondering from an institutional perspective, what did that look like for them to get behind you?
Yeah. That's an interesting question, because oftentimes there's a big gap between the academic institution and how the community perceives them. And so we wanted to earn people's trust. So we did it a few ways. One of them was by having people who were part of the study be of their same background. So all of the research assistants on both of those studies were racial and ethnic minorities. And I think that helped tremendously. We were out in the community in the second study. Actually, in both studies, we were out in the community because we had community meetings, the asthma study in churches and boys and girls clubs. In the second study, we were out there with them. And I think it gave them a chance to size us up and decide whether we were trustworthy. I think the whole concept of parent mentor was the key. So these are people like me from my neighborhood with the same kinds of challenges that my kids are facing, and they're here to help me. And that's a kind of trust that I think you can't get if you're in the Ivory Tower Medical Center and you have a PhD, and even if you're from the same racial and ethnic background, you may not live in the same community, you have a different SES stratum. And so I think that really resonated with them. And plus, you saw that these people were employed in the community and giving back to the community. So I think that's just such a powerful combination and why we were so successful with it. All right, any more questions? Well, thank you very much.